Next, we go to Dr. Anirudh Agarwal, who is an authority on ocular imaging and ocular imaging. You will be talking on imaging techniques, what's hot and what's not. Anirudh, please.
Very good morning, and thank you for this opportunity. So I'm going to be focusing on imaging of the choroid in non-infectious uveitis, and we'll see what is hot and what is not. So when it comes to imaging the choroid, we know that we have many lesions which we encounter in clinical practice, and we need to characterize them using imaging. So whether you have a good clinical description or not, the imaging becomes very important when you have lesions, especially when you can't see the whole lesion itself, especially when it's deep in the choroid. Now let's look at this example. So you have a patient with a yellow lesion in the superotemporal periphery, and you need to look at it more. Now, if you do the fluorescein angiography, often it's not very contributory. You will find some hyperfluorescence, which increases, but again, you don't really know the characteristic of the disease. So this is when we need to define a phenotype, and we need to understand how it is different from the lesions which require active treatment. So this is a patient with multifocal choroiditis, but this is a patient, I'm sorry, of unifocal choroiditis of a tubercle, where you have a single, or it could be multiple small discrete lesions with a central core, and usually when you see them, they are inactive because the patient has already had disseminated TB and the lesion itself is quite inactive. But we are concerned about multifocal choroiditis, which we more often see in our clinical practice, which has a phenotype that could be confused with MPE and other multifocal choroiditis garden variety, and this is where again the choroidal imaging plays a role. So let's look at this patient, and this patient, looking at the fundus image, you can probably make out that there is fluid in the center of the left eye, and you have a yellowish lesion just inferior to the macula, to the center. And look at the fluorescein here, it shows you hypo, and then eventually the lesion is hyperfluorescent, and you have pooling of the dye. So this is a classic example of a TB choroidal granuloma. And on the fluorescein, when you have a lesion which is hypo to hyper, along with the accumulation of fluid, that is a very good clinical sign of TB choroidal granuloma. And often these come with intense neovascularization over the lesion. Neovascularization can be made out on the fluorescein by looking at vessels which are dipping down into the lesion, or you may have pre-retinal hemorrhages, or you may even have intense hyperfluorescence, which you may not encounter in patients with sarcoidosis. So now this is another patient here who has lesions in the center, and you can see that there is diffuse sort of a geographic pattern of hyperfluorescence, and you have a CME in the late phase along with disc hyperfluorescence. The ICG shows you a central area of hypofluorescence, and which is more prominent in the late phase. But if you look at the periphery and the mid periphery, you have some small diffusely distributed hypofluorescent lesions as well. Looking at the OCT, you have subretinal fluid and you have bumping of the choroid. And to identify this bumped up choroid and focal thickening of the choroid becomes really important, because this will lead you to the diagnosis. So this is a patient of sarcoidosis, and this patient, as you can see, has a limited amount of, going back to the lesion, you will realize that the lesion has limited amount of yellowness inside the lesion. A TB lesion is generally more yellow, more bright, and associated with much larger volume of fluid, whereas this patient will have much less amount of fluid and you'll have a less intense appearance, and this is true for a granuloma. So moving forward, looking at the imaging, you can possibly lean towards a particular diagnosis. Now, when you talk about choroidal granulomas, TB granulomas, of course, can present with a granuloma or a subretinal abscess, and subretinal abscesses are a form of TB where you have severe exudation, rapid necrosis, and destruction. Now, we did some work in PGI differentiating TB versus sarcoid choroidal granulomas, and you can realize that with the EDI OCT, you can monitor these granulomas very well. So, an EDI OCT passing through the granuloma can show you the entire extent, the anteroposterior as well as the lateral extent of the granuloma. So in this patient, you have a full thickness choroidal granuloma in the right eye, and the CT chest gives you calcified mediastinal nodes which are suggestive of sarcoidosis. So even the OCT looks very classic of sarcoid. you don't have the excess exudation or fluid accumulation that you would see in patients of TB. So when you use EDI OCT, you can monitor these granulomas on the EDI OCT. So when I'm faced with a patient who has either a posterior pole or a mid-peripheral yellow lesion, I think OCT is the first investigation that I like to do. So in this patient, as you can see, during the follow-up, the lesion has decreased in size. The anteroposterior extent decreases first, and thereafter the lateral extent will decrease. So EDI OCT is very useful. Even if you don't have ICG, you can monitor these lesions on EDI OCT itself. Now, depending on the OCT appearance, fundus appearance, you can sort of categorize and differentiate TB versus sarcoid granulomas. And for example, in this on this slide, you can see that the location of granulomas are much more in the sarcoid granulomas are much more in the macular area, whereas TB granulomas could be perivascular or even extramacular. They could be in the mid periphery. Sarcoid granulomas will definitely involve the macula, and they could have a widespread distribution. Again, as far as the color of the granuloma, I told you that the TB granulomas are definitely more intense yellow compared to the sarcoid granulomas. Presence of subretinal fluid, and really a lot of subretinal fluid, goes in favor of TB, and partial thickness involvement is more in favor of sarcoid. TB granulomas are usually a full thickness involvement. So moving on from the TB and sarcoid, this is kind of stuck. So here, an important feature on the OCT that you can see differentiating TB and sarcoid is outer retinal infiltration. So here you can make out that in this patient you have some kind of an RPE sort of focal elevation, and you have this outer retinal infiltration. This outer retinal infiltration is quite characteristic of TB. So you could use it as a clinical sign to differentiate TB versus sarcoid. Sarcoid granulomas do not have an outer retinal infiltration, and that could be a good clinical sign. Now, using ICG, we have started to sort of binarize even ICG, and we've had some talks in the AIOS about quantification, and now we are beginning to quantify even ICG images. We have already quantified OCT, and Dr. Rupesh has done a lot of work on choroidal vascularity index, and this could be very good quantitative measure to look at the response to your treatment. So the CVI is probably a better indicator compared to choroidal thickness, looking at the morphology of the lesion and the response to treatment. So this is available on the COIN network, which is the Comprehensive Ocular Imaging Network by Dr. Rupesh. Now, this is another picture here where you have two patients. The top panel is a patient of choroidal granuloma, and you see a single large granuloma, whereas the bottom image is that of a sarcoid granuloma. Now, you realize that the patient with the large granuloma has an intense yellow appearance, lot of fluid, and this is TB, whereas the second patient down below has these multiple granulomas which are small in size, and these are more in favor of sarcoid. This is an OCT of sarcoid granuloma. So you can see it's a very well behaved kind of a granuloma. It remains in the choroid. It doesn't cause that much of a choroidal elevation, and there is minimum or no fluid associated with it. So I'll skip this. So you can also use your ICG along with complement it with OCT angiography to identify white dot lesions or the white dot spectrum. So this is a patient with a placoid lesion on the ICG, and the OCT shows you a very characteristic ellipsoid zone disruption. There is a photoreceptor disruption also, and this lesion, which is hypo to hypo on ICGA, is highly suggestive of MPE. And when you do an OCT angiography, you will have the exact colocalization of the fluid, the flow void areas. So it very much matches the ICG. So MPE is a type of a choriocapillaritis with a confluent pattern. Now this is another patient who has blurriness and spots, and you can see multiple hypo lesions on ICG. And this is where doing an ICG becomes very important in practice, especially when you're looking at posterior uveitis. So the ICG in the late phase shows you these multiple hypo lesions. And this is a classic case of mutes where the lesions are hypo to hypo, but they could also be ISO in the initial phase. And the OCT is quite characteristic, where you have this kind of an appearance of the outer retina with a disruption of the ellipsoid extending up to the outer nuclear layer. But remember here, the RPE is intact. This is versus the MPE patients. Here the RPE will be intact. And when you do an OCT angiography, you realize that there is no disruption of the choriocapillaries and there is nothing. So although you have these hypo lesions on ICG, you have nothing on the OCTA. This is my last patient with scotoma and decreased vision in the right eye. And you see the contrasting appearance on two types of autofluorescence. One is the blue ray autofluorescence and the other one is the near infrared. And you realize that on blue filter you have hyper autofluorescent and the lesions appear hypo or near infrared. And the moment you see this with no finding on OCT angio, you know that this is MUDES. And the MUDES patients will have intact choriocapillaries. So the goal of my talk is to use these imaging modalities in a particular sequence and use a targeted imaging to see the pathology and then narrow down your differential diagnosis. Thank you so much. Thank you.
So that was a very nice and exhaustive presentation, sir. Dr. Natasha, can you just, for the benefit of all of us, just summarize basically we always have this confusion between the TB choroiditis and the sarcoid one. Can you just briefly summarize, although Dr. Anirudh has very nicely explained exhaustively?
So from what he has told us, we can understand that the sarcoid granulomas will be more in the macular area and most of them will involve the macula. Other TB will be seen more in the mid-periphery and sometimes perivascular. And he has also told us that both these granulomas, when you image, you can see that they reduce in size first vertically and then horizontally.
I think neovascularization.
So you need EDI imaging for that.
Yeah.
These beautiful EDI pictures actually are not available on most of our OCTs. You really need high resolution imaging to make out that kind of difference. Yeah, I think it's probably very difficult to just use imaging alone to differentiate the two. It can only be used as an adjuvant to whatever investigations that we are doing.
I'd like to ask Anirudh, we know that OCT, if you do an N-phase OCT for tuberculosis or sarcoid, okay, would it give because last previous session there was a question was there for the N-phase OCT, and what is very interestingly, whether it can give additional information, particularly to localize the RP changes for sarcoid and TB.
I have not particularly used NFAS imaging to look at the RP or the choroid. Usually NFAS will be useful for localizing the extent of choriocapillaritis. So often you may not be able to see much on fundus photographs, but you could use the NFAS imaging to look at the extent. But to look at deep choroid, I have not used NFAS imaging. There's a question, I think, at the back.
It was a wonderful talk, very lucidly explained.
I think there's a question.
Yeah, Anirudh, fantastic talk. Just wanted to ask you about the outer retinal infiltration which you were showing. Is it the same as the contact sign which we talk about in cases with a granuloma, tuberculoma, or a sarcoid granuloma? Is this the same as one? And my second question is that what is your take on using pseudocolor imaging or a multicolor imaging in cases of uveitic entities, especially the non-infectious uveitis?
The contact, this is probably the contact sign, but I'm not sure if we have the exact same pathology of the contact sign and this outer retinal, because the contact sign is more, it's probably more full thickness compared to this kind of the infiltration that we are seeing. So I'm not sure if it's exactly the same pathogenesis. The second question I think is really important, pseudocolor. We don't rely on pseudocolor usually for posterior uveitis. I'd like to have true color images. Unfortunately, we all of us, we don't have that much access to true color images anymore. We have to rely on Optos, or we have to rely on these pseudo color images. So that's where I think the clinical examination I think has come back to being very important, because we have published it recently. You can miss an entire lesion, an entire choroiditis lesion on pseudo color imaging. So if you just depend on pseudo color, you may miss complete pathology.